Alright class, this is chapter 12. This is going to cover obtaining a medical history as well as vital signs. Alright, the objectives. We're going to define the following terms: auscultation, baseline vital signs, blood pressure, capillary refill, chief complaint, cyanotic, diaphoretic, diastolic, medical history, mental status, OPQRST, this is an acronym, palpation, pulse, respiration, sample history tool, sign, stethoscope, symptom, systolic, trending, vital signs, work of breathing. Objective number 2 is explain the importance of a thorough medical history. Number 3, differentiate between a sign and a symptom. Number 4, describe the components of the sample history tool. Number 5, describe the components of the OPQRST assessment tool. Number 6, explain the role that monitoring vital signs plays in the overall assessment and care of the patient. Number 7, state the characteristics that are obtained and measured when assessing respirations, pulse, blood pressure, skin signs, and pupils. Describe the methods used to assess each of the 5 vital signs. Differentiate the techniques used to assess a pulse in an infant, a child, and an adult. Differentiate normal and abnormal vital sign values for infant, child, and adult patients. Demonstrate the ability to properly obtain and adequately trend and document vital signs. Demonstrate a caring and compassionate attitude with classmates and the simulated patient. Alright, obtaining a medical history. Alright, medical history. This is a list of previous medical conditions and events for a patient. Signs. These are something you can see or observe about the patient, such as pale skin, rapid pulse, open wound to the chest. They're all going to be visibly obvious. Alright, so this image demonstrates somebody getting down to eye level with your patient. Make good eye contact as you begin to obtain your medical history. Alright, symptom. Something that the patient feels or more may complain about. It can be obvious or very subtle. These can include pain, nausea, just generalized weakness, anything that the patient may feel that you can't visibly see. This is table 12.1. This gives a list of common signs and symptoms. Some common signs that we can actually see are blood pressure, pulse, respirations, skin color, temperature, moisture, bleeding, pupils, bruising, unresponsive, confusion, or deformity. Like I said, these are all things that you can either see with your own eyes or you can measure with a device, you can hear it. They're all things that you can interpret with your 5 senses. Symptoms, on the other hand, are things that the patient feels. Some common symptoms are pain, nausea, shortness of breath, chest discomfort, headaches, dizziness, blurred vision, fatigue. Cough can be something that could go under a sign or a symptom, or anxiety. You can see the signs of anxiety, but not really the symptoms that the patient's actually feeling. But you can measure some abnormal signs that occur because of an anxiety attack. So the takeaway from this is signs are things that you can observe through your senses, and symptoms are what the patient feels, and a lot of times they have to actually describe it to you. Alright, obtaining a medical history. Now you're going to start out by interviewing your patient. An alert patient is the best source of information. They generally know all their own history, and they're able to give you a detailed account of their medical record. It's not always the case, but most of the time it is. Chief complaint. Um, you're going to ask your questions slowly and clearly. Allow for the patient to process and respond. You're going to listen carefully. And you're going to document important details. So a chief complaint is the number one reason why they have activated the 911 system. They may have multiple complaints, but there's generally one specific reason why they have chose to activate the 911 system, and that's going to be our chief complaint. All right, so when you start interviewing your patient, you want to establish a good rapport. This is best done by giving a good introduction. You're going to ask for consent to treat the patient. You're going to get their patient's name and use it. A lot of times you'll see individuals refer to a patient as sweetie or honey or whatever name you may use. That's not exactly appropriate. I like to get my patient's name, and I generally refer to them by Mr. or Mrs. or Miss with their last name. It's just the proper way to do it. Try to stay away from calling people sweetie, honey. It's just not professional. You want to obtain their age, and you want to obtain the chief complaint. We talked about the chief complaint earlier. The chief complaint is the main thing that they called you out there for. They can have other complaints, but that is the main reason that they're activating the 911 system. All right, when you're interviewing a patient, it's good to use tools to be able to go through your assessment and make sure you don't miss anything. So when we're obtaining a history, we use this sample history tool. All right, the S includes your signs and symptoms, which we discussed earlier. A is for allergies. This is generally, we're looking for allergies to medications that we may be going to give or assist the patient with. And this can also be for environmental allergies, such as a bee sting or something like that, if we're trying to figure out maybe what's going on with them. The M goes for medications. This is what is the patient taking. This includes all medications, whether they be over-the-counter or prescription. Past pertinent medical history. The key word here is pertinent. That means important history that goes along with what's going on right now. I don't need to know if you stubbed your toe or cut your foot 10 years ago and had to get 3 stitches. That's not really the medical history I'm looking for. But if you're having trouble breathing, I want to know what kind of medical problems you have, such as COPD or asthma or anything related. I want to know if you have any type of cardiac history. So just try to keep it pertinent to the complaint. Last oral intake is important, so you know what's in their stomach and what they could possibly be vomiting and aspirating if worst case scenario comes to be. So you want to know what their last oral intake was and when it was. That way you can pass that off to the EMTs and paramedics, who in turn can also pass that off to hospital staff in case the patient needs to go for surgery or something like that. And you also want to know the events leading up to the illness or injury. You want to know what were you doing when this started. A lot of times that can give us an idea of what's going on. If somebody was sitting on this couch perfectly fine and suddenly started having chest pain and shortness of breath, it'll bring to our attention, hey, this is probably something major going on. It's going to be acute onset without being induced by any physical activity. Where if you've got somebody that's been out running and they generally don't run, they decided to go run 15 miles and they're having shortness of breath and some chest pain, we're still concerned about it, but we can look at the situation and say, okay, I think that this is also possibly induced by the exercise. We have another possible reason or possible differential diagnosis where if somebody's sitting on the couch and they suddenly start having excruciating chest pain and shortness of breath, my index of suspicion is higher that we have some type of cardiac issue going on. All right, interviewing your patient continued. OPQRST is the most commonly used assessment of pain or discomfort. The O goes for onset. This means when did the pain or whatever symptom you're feeling start. P is for provocation. This means what makes it worse. Quality means describe your pain. Is it sharp? Is it dull? What does it feel like? The region / radiate is for R. Region means where is the pain occurring, and the radiate is does it move anywhere. So if you're having pain in your chest, does it radiate to your left arm? That's what we're looking at there. Severity is how bad does it hurt. We generally measure that on a scale of 0 to 10, 0 being no pain at all, 10 being the worst pain you've ever felt in your life. The answer is always 10 most of the time. And the time, how long has the pain been hurting? All right, some additional places you can get information. If you've got somebody that's unconscious, you can get this from family members, bystanders, other first responders that may have arrived before you, and medical identification jewelry. This is a lot more common than you think. Actually, last night I was at work and had an individual that was walking across the street and he was struck by a SUV, and the SUV just kept going. When we get there and he's unconscious, he's in really bad shape, and I don't have any information whatsoever. Best I could do was talk to bystanders, and they were only able to tell me that the guy was walking across the street and he was struck by a large SUV, and the SUV sped off. Didn't give me any real information, but I attempted to gather some additional info from the bystanders. You got to do the best you can. All right, here's something just to think about. When you're attempting to treat an unresponsive patient, the family members or bystanders are not on scene to help provide information. How can situational awareness help get some information you need? So, if you've got somebody that's unresponsive and they're by themselves, best thing to do is just kind of look around the room. Do you see any pill bottles? The pill bottles with their name on it may indicate what type of illnesses they have or what type of disease processes they have that they take medicine for every day. You may look around. Is there any drug paraphernalia around? Is there any, alcohol bottles? Just be aware of your surroundings, and a lot of times you can gain a lot of information just by looking around. All right, this is just an image of the paramedic or whatever her level of provider is obtaining some information from a bystander for an unconscious patient. All right, let's think about this. You become suddenly ill and a medical provider begins asking you personal medical questions. What would make you more likely to be honest and answer the questions in a forthright way? So when you're asking people these personal medical questions, you need to make sure they're in an environment they're comfortable with. You don't need to have them around a bunch of people that they may or may not want to hear any sensitive information about. You want to let them know that you're there to help them. You're not there to judge them. Just make them feel comfortable. Keep them private, and they're generally a lot more able to work with you. All right, and how could you apply this answer to your own assessment practices? That's going to be something you guys are going to have to think about, but that's very important, especially in more rural areas like ours where the communities are small. You got to give people privacy, and you got to make them feel comfortable when you're asking them these personal questions. All right, how would you handle questions such as, have you been drinking? Have you taken any drugs that are not prescribed for you? Is there a chance that you could be pregnant? So again, this is asking, put yourself in the position of the patient when you may have a bunch of bystanders around. And you're asking them, have you been drinking? How are you going to respond to that? You may be offended by that. You may, not want anybody to know that you have been drinking, whether you have or not. Same with the next two questions. Have you taken any drugs that are not prescribed to you? Most people don't want to broadcast that they're taking illegal drugs. Some people do. That's just part of life in the society we live in. But you don't have to broadcast it to the entire world that they're doing illegal drugs. All right. Another one is there any chance you could be pregnant? A lot of times that's a very sensitive subject, and you just need to be very careful how and where you ask this question at. All right, basic vital signs. All right, vital signs include respirations, pulse, blood pressure, skin signs, pupils, and perfusion. All right, mental status. The level of consciousness, or LOC, you'll often see it abbreviated. It's also referred to as a level of responsiveness. You evaluate it using an AVPU scale. This is another way we try to remember things. So AVPU goes AVPU. The A means the patient is alert, able to talk to you. They notice you when you walk in. They're completely alert and aware of their surroundings. V stands for verbal. This means they may be laying there with their eyes closed, but if you say their name or you speak, they're going to open their eyes and look towards the source of the stimulation. Responsive to pain is what P is for. It means they only respond to painful stimuli, which means you would have to physically shake them or cause a painful stimulus for them to open their eyes and look at you and be alert. And unresponsive just means that they're completely unresponsive. They don't respond to verbal or painful stimuli. It doesn't matter what you do, they're still going to remain unconscious. All right, baseline vital signs are the first set of your vital signs obtained. Generally, I like for people at work when I'm training them to be able to obtain their first set of vital signs within 5 minutes of arriving on scene and making patient contact. This just gives you a good starting point, knows where you're at, and it sets us up for trending, which is our next topic. So what trending is comparing multiple sets of vital signs from the same patient over time. So if you get your first set of vitals 5 minutes after patient contact, and you take another set 5 minutes after for a critical patient or 15 minutes after for a non-critical patient, you can see how the patient's condition is doing based on the vital signs. If they're staying the same, you know your patient's not really deteriorating too bad. If you're trending and you're having significant changes in the vital signs, maybe what you're doing is not working and maybe you need to do something else or be a little bit more aggressive with what you are doing. All right, you got to have a careful analysis of the vital signs. They can alert you to current or developing problems like we just talked about. Don't rush to a conclusion too soon. Don't get tunnel vision. It's just not a good idea. All right. All right, respiration. This is the act or process of breathing. You're going to evaluate the rate, the depth, the sound, and the ease of respirations. The work of breathing, that is the effort that the patient must exert to breathe. It means how much are you working to be able to breathe. This is table 12.2. It's in your book. Here's some different observations that we can actually see, and we can see that they're signs that we can look to give us the idea of a possible problem. So rapid shallow breathing can be heart problems, heat emergency, diabetic emergency, heart failure, pneumonia, or shock. A lot of things that can cause these rapid shallow respirations. Deep gasping or labored breathing can be an airway obstruction, could be heart failure, lung disease, chest injury, or a diabetic emergency. Slowed breathing can occur from a head injury, stroke, respiratory failure, or narcotics overdose. Snoring can occur simply from your tongue being partially obstructing your airway for no particular reason. Could also occur from a stroke, fractured skull, drug or alcohol overdose, and it does always indicate a partial airway obstruction. Crowing, crowing. This is going to be partial airway obstruction. It's going to note swelling of the airway. Gurgling, this is always going to be an airway obstruction due to fluids. You can also have fluids in your lungs that can cause gurgling noises. Wheezing generally occurs in conjunction with asthma or emphysema. It can also happen with a lower airway obstruction that's allowing some air to pass by but not much. Also can occur in heart failure, but it's a different mechanism for the wheezing when it's a heart failure patient. Coughing blood can occur from a number of different things as well, but some things it may alert us to is chest trauma in the traumatic victim. It can be from a lung infection, it can be from a punctured lung, it can be from other internal injuries. All right, respiratory assessment. All right, so you're going to grasp the patient's wrists as if you were going to count their pulse rate. Hold his arms firmly against his upper abdomen. Observe the abdomen and chest move in and out. Listen for abnormal sounds. So the reason that you're grasping the patient's wrist and hold the arm firmly against his upper abdomen so you can see as well as feel the respirations. It just makes it easier for you to be able to evaluate the effectiveness of the respirations. All right, how might the respirations be inaccurate if the patient is aware that he or she is being assessed? What strategies might the EMR employ to avoid this? So this is something that occurs frequently. If I walk up to you and say, hey, I'm about to count your respirations, breathe normally, you're immediately going to start breathing abnormally. So that can affect your rate, it can affect your depth. I like to count my respirations while I'm doing something else, keep them preoccupied, ask them questions about something else, and they're just going to continue to breathe without really thinking about it. If they start thinking about it, things are going to get weird. All right, respiratory assessment continued. You're going to count the number of breaths a patient takes in 15 or 30 seconds. You're going to do this, and then you're going to have to multiply that by 4 or 2 respectively. Just depending on how long you counted that. We'll talk about that in class. All right, while counting respirations, you're also going to take note of the depth and the work of breathing. And you're obviously going to document the rate, depth, and ease. All right, average respirations by age. These can be pretty significantly different depending on the age. Adults generally going to breathe 12 to 20 breaths a minute. Adolescents are close to the same as adults, but you're going to see 12 to 16 breaths per minute for the adolescents. School-age children, this starts to increase. You'll see a rate of about 18 to 30. A preschooler, which is going to be 4 to 5 years old, is going to be 22 to 34 breaths per minute. Toddlers, which are 1 to 3, you're going to see a rate of about 24 to 40 breaths per minute. And somebody less than 12 months, their respiratory rate can vary widely, and that a lot of times just depends on the stage of development they're in from birth to 12 months, but it can be anywhere from 30 to 60. This is something you need to spend some time to know, because this will be constant throughout whatever training you go to beyond this. This is a very important table. It's in your book. All right, this is an image of a EMR assessing the respirations of a supine patient. You see how she's got her hand with the patient's arm over their abdomen. It's just a tool for her to be able to assess the breathing in more than one way. All right, same situation, but the individual just seated. All right, pulse. Get a remote heartbeat. Gives insight into the circulatory status of the patient. Good pulse indicates blood is moving well throughout the body. So as soon as I walk up to a patient, I introduce myself, ask what the reason they called 911. I'm simultaneously checking for airway. If they're able to speak and talk to me, their airway is generally going to be open and clear. I'm assessing their breathing status. Are they having trouble talking to me? Do they look like they're in any respiratory distress? As I'm doing that, I put my hand on their wrist if they're conscious. This gives me a good picture of what's going on with the patient. And I'm not necessarily counting the pulse when I immediately walk up to them. I just want to feel, is it there? Is it way too fast or is it way too slow? We're going to actually count the pulse when we're obtaining vital signs. Different pulse points are central pulses, which include your carotid. That's on the side of your neck. That's where you check a pulse for in an unresponsive patient that you suspect might be in cardiac arrest, or femoral. That's a less common pulse, especially for people in the field, because most of the time individuals have clothes on, and the femoral pulse is not exactly the most accessible pulse point. It's one of the best ones to check, though. If you know where it's at and you're able to appropriately access it, it's great. Peripheral pulses include your brachial, your radial, or your pedal pulses. The most common pulse point to check on an adult patient is radial. On a young child is generally the brachial. It's just an easier, larger anatomy that you can actually feel a good pulse in. All right, so this is an image of locating the carotid pulse point on the neck. We will go over that in class. Just note where his fingers are pressed. This is again something we'll do in class, but this is how you locate the radial pulse. Now, so when we're checking vital signs and checking the pulse, we're assessing for rate, strength, and rhythm. This is commonly referred to as rate, rhythm, and quality. Quality being the strength. All right, so if you've got a responsive patient that's sitting up talking to you, we're going to check the radial pulse. If you got an unresponsive patient, you're always going to go for the carotid pulse, and in certain situations, maybe the femoral pulse. A radial pulse may not be detectable if the blood pressure is too low or if there's an extremity injury. Just keep that in mind. If you don't feel a radial pulse, just go to a central pulse such as the carotid. All right, pulse rate for adults is between 60 and 100 beats per minute. If it's above 100, it would be considered tachycardia. If it's below 60, it's considered bradycardia. Pulse point for infants under the age of 1 year is the brachial pulse in the upper arm. Like I said, the anatomy in the upper arm is just bigger. You can feel it a lot easier. It's just too much involved in trying to check a radial pulse in somebody that young. Their anatomy is just too small. Capillary refill. This is the time it takes for capillaries to refill after being blanched. So the process for this is going to be to select the appropriate finger or toe that you want to use. This can be any finger or toe. Using your thumb and your index finger, you squeeze the pad of the finger or the toe from both sides. You're going to observe the pad as it blanches. What it means by blanches is turns white. All right, so after you quickly release the pressure, you're going to observe the return of color to the pad. And the return of the color that you're looking for is just going to be the same as the rest of the fingers, and you're going to time how long that takes. You just make sure you document the findings. All right, this is an image of someone checking capillary refill. So he's squeezing the pad of the finger on both sides. You can see it's blanched or white in the area at the very top. When he releases it, we're going to count how long it takes to go back to a normal color, and that's going to be our capillary refill time. All right, blood pressure. This is going to be the measure of pressure of blood against the walls of the arteries, both when the heart beats and when it's at rest. This means when it beats, it's going to be in systole, or this is your systolic pressure. Like I said, it's just the pressure within the arteries when the heart is actively beating during the contraction phase of the heart. The diastolic pressure is the pressure that remains in the arteries when the heart is at rest. This is just going to be, like I said, during the resting phase of the heart. So your heart has a active phase and a resting phase. During the resting phase, it's refilling with blood, and that's going to be the bottom number on your pressure. All right, reading of 120/80 is considered a normal blood pressure. You're going to take several readings to identify changes in status. That's what we were talking about, trending. Systolic reading above 40 is considered high blood pressure or hypertension. And this is a chart going over the average blood pressure by age. Adults, this is going to be anybody over the age of 18. The systolic number, we're hoping it's under, right at 120 or under. And this diastolic, we want it to be right at 80 or lower. Adolescents, this is 13 to 17. It's roughly the same as an adult. But you got 113 to 131. And the bottom number of the diastolic is going to be 64 to 83. This is where significant changes start to occur. This is going to be the school-aged children. Systolic pressure can run from 96 to 115 and be considered normal, and the diastolic can be from 57 to 76 and still be considered normal. A child 2 to 6 is going to be 88 to 106 on the systolic or top number, and 42 to 63 on the diastolic or bottom number. Keep in mind, these numbers aren't hard and fast. They're just an average range that we would consider normal. Anybody under 2 years old, I'm generally not even going to attempt to check their blood pressure.
Following your initial patient assessment and control of any immediate life threats, you should obtain a baseline set of vital signs, which include pulse, respirations, skin color, temperature and condition, pupil size and reactivity, and blood pressure. The baseline set of vitals gives you a beginning place from which to make treatment decisions. As you retake vital signs, you will compare the readings to your previous findings. This is called serial vital signs. Serial vital sign assessment allows you to note trends in the patient's condition, such as a declining blood pressure or increasing respiratory rate. When measuring blood pressure, you will use a blood pressure cuff and a gauge called a sphygmomanometer. You can collect readings by auscultating or listening to the characteristic clicking or thumping sounds with a stethoscope. Or, when the environment is too loud or the Korsakoff sounds too soft, you can palpate the blood pressure, which means to feel the radial or brachial pulse with your fingertips while using the BP cuff. To report blood pressure readings, use a blood pressure fraction. The top or first number reported is the systolic blood pressure. This is the pressure created when the heart contracts and forces blood into the arteries. The bottom or second number is the diastolic blood pressure. It measures the pressure remaining in the arteries when the left ventricle releases and refills, or the residual pressure in the system. A normal blood pressure for the average adult is around 120/80. Hypertension is defined as consistent readings with a systolic blood pressure over 140. Low blood pressure, or hypotension, is usually considered a systolic blood pressure below 90 millimeters of mercury. Begin the blood pressure measurement by removing or rolling clothing to expose the bare skin of the arm. Be sure that the sleeves, when rolled, do not occlude the arteries of the arm, preventing blood flow. If the shirt is that tight, remove the arm from the sleeve. Select the appropriate size BP cuff. The cuff should measure 2/3 of the length of the upper arm, from elbow to shoulder. Additionally, it should be long enough to fasten the Velcro securely when the cuff is placed circumferentially around the arm. Place the cuff on the bare arm, following the illustration on the cuff for placement over the artery. With your fingertips, locate the brachial pulse on the medial upper arm near the antecubital fossa or crease of the elbow. Place the diaphragm or bell of the stethoscope over this pulse point. With the bulb valve closed, inflate the cuff until the pulse is no longer heard or felt. Using the stethoscope, listen for the sound of the pulse returning as the pressure in the cuff is slowly released. Note the number on the cuff's gauge as soon as you hear the first pulse beat. This is the systolic pressure, the top number of the BP fraction. Continue to deflate the cuff, this time listening for the point at which the beats fade. Again, note the number indicated on the gauge. This is the diastolic blood pressure, the BP fraction's bottom number. Since you now have both your diastolic and systolic measurements, let the cuff deflate rapidly. Record the measurements and the time. Blood pressure is recorded in even numbers. As already mentioned, you may find yourself in a situation where it is impossible to hear an auscultated blood pressure due to external noises on scene or in the back of a moving ambulance.
In such cases, an estimated systolic blood pressure can be obtained by palpation. Since the palpated blood pressures are usually lower than actual blood pressures, an auscultated blood pressure should be taken as soon as possible. The steps for palpating blood pressure are basically the same as used for auscultation. The obvious difference is that you do not rely on a stethoscope to hear the presence or absence of Korsakoff sounds. Begin by palpating for the radial pulse. Inflate the cuff until the radial pulse disappears. Then slowly release air from the cuff until the pulse reappears. At that point, check the gauge for the systolic blood pressure. Report your findings as the systolic blood pressure over P for palpation, as well as the time of the reading.
All right, auscultation. Auscultation just means listening. All right, so this is going to be listening to the internal sounds of the body with a stethoscope. You're going to have the patient sit or lie down. You're going to remove clothing on the arm. You're going to support arm at the level of the heart. You're going to select the correct size blood pressure cuff. Adjust the earpieces of the stethoscope so they point forward slightly into the ear canal. We'll demonstrate in class. All right, this is going to be the proper position for taking a blood pressure on a seated patient. And this is the proper position for obtaining a blood pressure on a patient that's supine. It's just a little bit of anatomy. If you look at the location of the brachial artery, it's indicated with the line and the dot. Alright, if you'll note the proper placement of the blood pressure cuff, you see on the square image on the blood pressure cuff itself, it says artery. You just want to line that up with the artery. Alright, pulse sounds will be heard through the stethoscope between the systolic and the diastolic reading. The red is indicated. That's going to be the pulse pressure, or the range between the top number and the bottom number. So in this particular image, the top number starts at 120 and it stops at 80. So you should be able to hear what you would call Korsakoff sounds through your stethoscope from the period of 120 down to 80. Auscultation of blood pressure. You're going to let the rest of the air out of the cuff quickly. Then you're going to record the time, arm used, position of the person, and the pressure readings themselves. Alright, in class we're going to get in pairs and we're going to check each other's blood pressures. We'll check multiple individuals' blood pressures. Alright, going to place the cuff snugly around the upper arm as the first step. Palpate the brachial pulse point and place the diaphragm of the stethoscope directly over the pulse point. You're going to close the valve and inflate the cuff. Generally recommended to 180 millimeters of mercury in an adult, 120 millimeters of mercury in a child. I'm going to show you guys the alternative method that I prefer in class, but we'll go over both methods. You're going to, after you get it to the pressure of 180, you're going to open the valve slowly to release the pressure from the cuff. You're going to listen carefully as you watch the needle move. You're going to let the cuff continue to deflate. Alright, this is just another image of proper blood pressure. And this is an image of them documenting their results. It's pretty self-explanatory. Alright, palpation. This means feeling. The actual definition of palpation is using one's hands to feel or touch the body. It's not a very accurate method of obtaining blood pressure. However, it is a way to obtain a blood pressure if you don't have another option. You get one reading. You get an approximate systolic blood pressure. The issue with palpation is you're generally going to get a little bit lower pressure when you palpate it than you would if you auscultate it. So most studies give you a range of 10 to 20 millimeters of mercury above the systolic pressure is what your actual systolic pressure could be if it was auscultated. Sometimes it's right on the money, sometimes it's not. It's just not terribly accurate, but it will give you a good idea of what their blood pressure is. Time would use it if there's just too much noise and you can't hear anything. If you're on a chaotic scene where there's just a lot going on, you got lights and sirens and heavy equipment running in the background and you just can't hear through your stethoscope, you're going to palpate it. Alright, this is how you would palpate the blood pressure. You just place the cuff like you would if you were going to auscultate it. Feel the radial pulse and inflate the cuff until you feel the radial pulse go away. That's going to give you your palpated pressure. Now, a lot of times, what I'll generally do is do this part and then I'll immediately auscultate it coming back down, but I'll go over that in class. Alright, after you lose the pulse, you're just going to continue to inflate it about 30 millimeters of mercury beyond where the pulse went away, just to confirm you didn't have a auscultatory or any type of gap between there. Alright, then you're going to release the pressure of the cuff and note the pressure on the gauge when the radial pulse returns. It's going to be the approximate systolic pressure. So like I said, you're feeling it twice. You're feeling it go away on the way up. Then you're going to go about 30 millimeters of mercury above it, and then you're going to feel it on the way down as well. Like I said, it'll give you a ballpark blood pressure. It's just not super accurate. Alright, skin signs. You want to look at skin color, temperature, and moisture. Are they pale or cyanotic? They look flushed. Are they jaundiced, which is like a yellow color to the skin? All right, skin signs, examples of skin signs: pink, warm, and dry, or PWD. This is normal. We want our skin to be pink, warm, and dry. Pale, cool, and moist is fairly common, but not necessarily good. Flushed, hot, and moist, or flushed, hot, and dry. These are just all ways to describe the feel and touch of the skin. All right, this is a table just for assessing the skin. We went over most of this in the last slide. You're definitely going to need to look over it and read it in more detail in your book. I'm not going to spend a whole lot of time on this slide. It's something you need to look over in your book, and we'll go over more in class as well. Alright, so use the back of an ungloved hand to assess the skin temperature and moisture. If you look at him, he's kind of got his glove peeled back, and he's just feeling her forehead. This is pretty unreliable. You can tell if their skin is hot sometimes, but it's very relative. Best way to assess somebody's temperature is with a thermometer, and you can definitely assess the moisture with the hand. It's, just the temperature is just something that's kind of unreliable. Alright, you're going to evaluate the skin color of dark-skinned patients. These would be our, individuals that have more pigment in their skin, such as, non-white individuals. You just got to pay a little bit more attention. You got to look at their oral mucosa, which is like the inside of the mouth and the lips. The conjunctiva, which is in the eyes, like around the eyes, the different colors that you get there. Got to check out the nail beds and the palms of their hands. You can always look at skin color there as well. Alright, pupils are very important. You want to take an initial note of the general direction they're looking in. Identify any obvious injury or deformity to the eye itself. Ensure that both of the pupils are round and about the same size. You got to note the reaction to changes in light. Constriction with sudden introduction of light is normal. And dilation to light when the pupil is blocked is also normal. Alright, pupils. This is what we use to evaluate them. PEARL stands for pupils. The P stands for pupils. The E stands for equal. This means they look the same. R is reactive. Do they respond to light? Alright, again, this is in your book, 12.7, but we'll go over it briefly. So dilated non-reactive pupils. Dilated means they're larger than normal, and non-reactive means they don't react to light. This can be during shock, cardiac arrest, bleeding or hemorrhage. Certain medication can cause this, and also head injury can cause it. Alright, so constricted, non-reactive pupils, which means super small pupils that don't react with light. This can be central nervous system damage, certain medications, also narcotics. Pain pills, heroin can cause this to happen. Alright, unequal pupils occur from a stroke or head injury. This is just a few different images of what pupils look like. A is constricted pupils. Again, this is what you'd see possibly in a narcotics overdose. Pupils are going to be super small. They're not going to respond to light. Alright, dilated pupils you've got here. Again, you can refer to the chart for the different causes of dilated pupils. And this is unequal pupils. One pupil is much larger than the other. This is pretty common in head injuries or strokes. Alright, here's some things to think about. Could vital signs ever be considered unreliable? Yes and no. Some vital signs that we obtain, such as pulse oximeter reading, can be very unreliable, especially if you're in an environment that there's high carbon monoxide levels, such as a house fire or something like that. Mostly, though, if I obtain vital signs or somebody that I know is competent has obtained vital signs, I consider them to be pretty reliable, and I can trend them, and I can pretty easily determine how the patient's doing based on their vital signs. All right, what does treat the patient, not the device mean? And why is it especially important to remember when working with automated or electronic vital sign equipment? Let's go back to the pulse oximeter reading. So a lot of times when you're using pulse oximeters, they'll give you a number that I can look at because I've got years and years of experience with a bunch of patient contacts, and I can say, well, that's not right. But it can give you a reading that's concerning, and a less experienced provider or someone with less training, or like I said, just less experience, could look at that and be like, oh my gosh, this number is awful. I've got to do this. On the flip side of that, you could have somebody that came out of a house fire that has been exposed to a lot of carbon monoxide. Their pulse oximeter reading could be 100, but they're sitting there just breathing, sucking air, and just having a major hard time breathing, but their pulse oximeter reading is going to be 100 because the carbon monoxide binds to the hemoglobin and it gives a false reading on the pulse oximeter. So you got this patient that their pulse oximetry reads at 100, but they are completely hypoxic and they're having an extremely hard time breathing. So if you're just treating what the machine says, you're going to withhold oxygen to somebody who really, really needs it. So you got to look at your patient. You've got to look at how they're presenting, and you've got to treat that. You can't just go off of what your machines say. I mean, they are sometimes unreliable. All right, summary of the chapter. It all comes down to a good patient assessment. You got to gather information about the patient and the chief complaint and obtain complete and accurate vital signs. Always properly introduce yourself and get the patient's name immediately when you walk in. Whenever possible, direct your questions to the patient. Try to ask them first. If they're not able to answer, then go to a family member or bystander. Speak clearly and confirm that the patient hears, understands, and answers each question before asking another. Use a sample tool to help guide questions, and always document the patient's answer. Again, SAMPLE stands for signs and symptoms, allergies, medication, pertinent past medical history, the last oral intake, and the events leading up to the whatever emergency has occurred. So as soon as you get there, obtain a set of vital signs to establish a good baseline. Again, I recommend getting a set of vital signs within 5 minutes of making patient contact. It just gives you a good starting point. You're going to repeat the vital signs frequently and compare previous readings to establish trends in the patient's condition. Most vital signs have multiple characteristics. Characteristics they're talking about are how you're going to describe the vital signs. And you're going to make sure you document that appropriately. All right, here's some review questions. All right, why is it important to obtain a thorough medical history? All right, if we obtain a thorough medical history, we can know what we're dealing with. We know what kind of medical problems the patient has, and we may be able to use that to help us out in treating their current emergency. Now, what's the difference between a sign and a symptom? A sign is something that we can observe through our senses, and a symptom is something that the patient is experiencing and they may have to describe to us. All right, what does SAMPLE represent? The S is for signs and symptoms. A is for allergies. These can be environmental or medication allergies. M is for what medications is the patient taking. These can be over-the-counter or prescription. P is for past pertinent medical history. What kind of medical problems does this patient have that relates to the current emergency? L is for last oral intake. What's the last thing you had to eat and when did you eat it? Events leading up to E is for events leading up to this emergency. This just means what happened just prior to this emergency. All right, what does OPQRST represent? O stands for onset. When did this pain or sensation start? What were you doing when this started? P is for provocation. What makes this pain or sensation worse, or also what makes it better? Quality means what did it feel like? This is Q. So Q is for quality. What does this sensation feel like? Is it sharp? Is it dull? Is it throbbing? What does it feel like? R is for radiation. Does this pain move anywhere? Are you having pain in your chest that also radiates to your left arm? S is for severity. Generally, we rate this on a scale of 0 to 10. 0 is no pain at all. 10 is the worst pain you've ever felt in your life. And T is time. How long has this been going on? All right, what role does monitoring vital signs play in the overall assessment and care of the patient? Now, you're able to trend how the patient's doing based on the vital signs. For instance, if we got on scene to a trauma patient, they've lost a good bit of blood, I'd expect my first set of vital signs to be maybe respiration 16, O2 sat. We're not even worried about O2 sat right now. Heart rate may be at 120. Blood pressures, for just purposes of it being normal, 120 over 80. 5 minutes later, I check it again. Respiration is the same. Heart rate still about 120, but the blood pressure is now 76 over 40. I can tell that they're continuing to lose blood from somewhere, and they're going into more severe shock, and it just lets me know that our patient is getting worse. It goes the same for if you got somebody that has lost some blood, you give them some fluids, and their heart rate comes down. Hey, what we're doing is working. What are methods used to assess each of the 5 vital signs? We're going to go over this in class, not something we're going to spend time on right now. What vital information is obtained through assessing respirations, pulse, blood pressure, skin size, and pupils? So this just gives you a complete picture of the patient. If you assess these things, you're able to just get a solid view of what's going on internally with this patient, and it can guide us in our treatment. All right, how do the techniques used to assess a pulse in an infant, child, and adult patient differ? The biggest one I want you to take away from here is when you're checking the pulse on somebody, an infant or a child, you're best suited to use the brachial pulse to feel for the pulse. That's just the biggest takeaway here. There's more that we'll go over in class and you can read in your book, but the biggest takeaway is using the brachial pulse because the anatomy is much smaller in the younger individuals. All right, how do normal and abnormal vital sign values differ for the infant, the child, and the adult patient? They just change as the patient's anatomy changes. The vital signs are different. If you refer to your charts in your book, generally younger individuals have higher respiratory rates and higher pulses than adult patients. I'm not going to list every way that they're different right here because you have the charts in your book and you need to be able to look over that and you need to pay a lot of attention to these charts. This is a practical assessment that we're going to do in class. If you want to take a look at it, you can. We're going to do things a little bit differently, but just read over that. Alright guys, this concludes chapter 12. Hope you guys enjoyed it. We're getting into some more significant stuff here. It's more directed to patient care. Things should start getting a little bit more interesting and we can be a little bit more engaging with everything. You guys got any questions, feel free to reach out to me. Alright. This is just a video. It's going to go over blood pressure assessment. It may come through, it may not. If it doesn't, we will demonstrate it in class.